So what I think the goal is I'll update on some of the stuff that we're doing with our INGENIOUS trial, which stands for Indiana Genomics Implementation and Opportunity for the Underserved. And then I'll throw some other things in, talk in the beginning about some of the, about some of the background on it, and we're starting to get into the data. We've actually completed enrollment now, so we're starting to really dive into the data. I'll talk about some of that. And then at the end, for the molecular biologists in the crowd, if there are any, I've got some stuff where we're developing some additional high-throughput functional assays to try and move more of the genetic variants and SNPs that we see in whole genome sequencing data, GWAS studies, into actually, into clinical type scenarios. So, with that, just to mention here again, we call it our INGENIOUS trial. It's one that's funded by the IGNITE network, and the primary endpoints of this are total healthcare costs, which is pulled out from the ER, number of adverse events, and we're really testing to see whether if we genotype the people ahead of time before they get there, or at the time it's a responsive genotyping activity. If we genotype them in patients that are getting one of 27 different medications, do we actually can we reduce their healthcare costs and the number of adverse events, both of which are probably linked together. So this was initially, we were starting in our Eskenazi Hospital, which is our county hospital, mostly underserved patients within Indianapolis, downtown. Underserved meaning Medicaid or uninsured, mostly, so they're mostly low-income patients, very diverse population. And then partway into the trial, we actually rolled it out into IU Health, which is a statewide healthcare system that has 17 hospitals across the state, of which we're now, or when we ended, we were enrolling from 14 of them. So we've stopped enrollment as of April 30th, or actually we had 5 days from the time when the script was written. So the first week in May, we ended up with 1,300, a little over 1,300 in the genotype guided arm, and about a little over 3,100 in the standard of care. And basically, what happens in this is anytime any patient in either the Eskenazi or IU healthcare system gets prescribed one of these 27 medications, we have a report that's generated every morning that tells us, yesterday, here's all the people that got one of these medications from both healthcare systems. Separately, we then look in that list and go back and see if they've gotten it before, because we only want patients with a new prescription for one of those medications. And then once we do that, in a couple of cases, there's some ICD-9-10 codes that we narrow down for, but for the most part, it's for any indication. That report also has the patient's phone number and their name and MRI number and phone number on it. So we then call them. In the case of Eskenazi, we call them if they're interested. Then we actually meet them. They come back in the hospital and in person enroll them, consent them, get a blood sample, then genotype them. In the case with the IU Health, because it's across the state in 14 different hospitals, and I'll show you where they are in a minute, we get the report. We do the same thing. We look for new meds, make sure they're not already on the trial, or they haven't already been randomized. And then if they are, we actually call them. And then if they want to enroll, then we have an online consent, so it's all done remotely. So there's the RedCap, they do that, and then there's a box, they can check a box which hospital they would want to go get their blood drawn, or somewhere, any of those 14 sites, or any of the ones downtown. And then we upload a requisition into the central IU Health system, where they then all they have to do is go show up at the draw station, and Todd, I'm here to get my blood draw for this trial. They'll see that the order form is there, pull it down, then it gets buried downtown. Well, IU Health is all done remotely with no direct interaction, and these are done. We contact them directly. We don't actually have to go through the provider first. So in many cases, the provider won't know about it until if there's an actionable genotype for the then we will actually send a direct note through Cerner or Epic that goes directly to the provider that says the patient's on trial. If they genotype, they have this genotype in this contraindication, or we think you should change medication based on X, Y, or Z, and it goes directly from one of our physicians that's part of our trial directly to the physician who's the provider. If there's not an actual genotype, there's no message sent back to anybody, and they just go on as they normally would. So, and the genotypes that are, the majority of the genotypes are the cytochrome P450 enzymes. These are the drugs, or the hepatic enzymes that are the major elimination route for about half of the 200 most commonly prescribed drugs. Now they can either activate or inactivate drugs. In some cases, if the prodrug gets activated, in some cases it's basically the elimination and detoxification mechanism. The FDA, these are obviously important because the FDA requires screening for metabolism through these enzymes for any new drug that gets developed before it can be approved, for both what metabolizes them and then what the if there's any potential interactions. If they're a substrate for one of these, then it's required that they go on and do some drug interaction, clinical drug interaction studies. So they are an important mechanism for getting rid of the drugs. So there's genetic variants, and they do some of the same things as these PK drug interactions. And so these are the SNPs that we're interested in within these genes. And after this has been developed for the last now about 8 or 10 years, I think the FDA has a voluntary submission of pharmacogenetic data that can be submitted also. This is so they have a guidance. You can that's actually how they suggest to do it. It's voluntary, and most places, most drug companies actually do it now if they're metabolizing these enzymes. So and then the FDA sometimes takes that or other evidence, and there's actually pharmacogenetic information in the FDA drug labels for over 100 drugs. It's actually quite a bit more than 100 now. And these are things for expression, genetic variants. They can be targets, drug disposition, or HLA. And as I was mentioning to somebody this morning, so metabolism is the ones that we're interested in. So back about 10 years ago when we started realizing, or when there was a lot of emphasis on these genetic variants and showing that they really impacted these drugs, the drug companies now had systems they could actually screen to figure out which enzymes they were metabolized by. And so there's a lot of emphasis to just avoid the metabolism by any of the drugs and make them so they were eliminated some other way. And so there was, there have been comments that, well, this really isn't going to be relevant in, a few years because all the new drugs that are coming out are not metabolized by this. Well, that's actually turned out not to be the case, despite them actually trying to do it. So they tried to avoid it to avoid these few patients that had the genetic variants. But if you actually look at the amount of, or the major routes of elimination, whether it's P450s in the red, so the cytochrome P450s in the red, versus non-P450s, or if there's actually no major metabolite, so it's just renal excretion. If you look at over time, 6 to 10, or here's 11 to 15, and so 6 to 15. But if you look really here, back when they're starting to do this, 43% were still metabolized by this. And then in the more recent ones, even more than that. So despite their actual efforts to try and avoid metabolism, I mean, they're really just, one of our main mechanisms for getting rid of xenobiotics and especially drugs. So I think it's not likely that it's going to go away anytime soon, especially if you look at the life of drugs. They're going to be around for a while. This is just a slide that's got the drugs with the different genes that are relevant, and then for each of the some of the star alleles and stuff. But if you can see it up there on a slide that shows the frequency of these drugs in a little bit. So just anybody interested in how we're genotyping. So we got 50 steps, 16 genes. It's done on the Quant Studio. These are the genotyping with the open arrays. Copy number variation for SNP2V6. We were talking about that this morning. It's done as a separate assay because that's more difficult to do. And we just use that because it's an accurate genotyping and flexible. So we've actually added and taken off some SNPs during the time because we use this chip for a few other things also in our oncology clinic. And we've added some new SNPs as there was additional evidence that was coming out. But it's done in a CLIA and CAP-approved lab because we're actually putting the data in the medical records so the providers can actually use it. If there's any questions, feel free to interrupt me as we're going through this.
Do you mark it as research use, or is it a research study so they know that from a research study, or is it just?
It's the report is put in as a PDF. In Cerner it's a PDF, and in Eskenazi it's as a text file, but like that. So it's not. It's put in as it can be used for clinical purposes. So it's not like a research only thing. And then with the other ones where we use it in the cancer clinic, it's purely as a clinical service. I mean, we may end up doing some research later, but it's done now. Clinical service. Okay, so this is the update, and this is actually was from a week or two before we finished genotyping. A few more than this, but this part here refers to when we get this every morning. We get this report that's got all the patients that had one of these drugs, and then we randomize them to once we go through and they're not a duplicate patient. They're not and they're a first time that they got one of these drugs, they get randomized, right? So the total number of alerts that we received that fit our criteria over the 3-year period was over 18,000 of these alerts that met that. We then, and it turned out there was 3,000 ended up in the control arm, or a little more than that, roughly 3,000 and 1,300. There was a lot of them, and actually a lot more than we actually anticipated, were randomized, but either were unable to reach or decline. A lot of these are because they were unable to reach, and I'll show you in a slide a little bit later that a difference between the different healthcare systems. A lot of it is exploring some of those things. It's because the patients don't, especially in an underserved area, don't necessarily answer the phone if it's coming from a hospital or if they don't know who it is. Some of them are on these phones. This is part of the Obamacare thing where they got some phones, but they only had a certain number of minutes. They use their minutes up before the end of the month. They actually don't have any minutes, so the phone's actually not active. Some of them couldn't, didn't want to participate. So there was some of those, but there was a lot of things in here that ended up with way more actually in the randomized but not enrolled as we thought. So all the ones in the control arm were not actually contacted. We're just pulling the data out of their medical record system. So it wasn't any of these. It's all these ones that are limited by that. It's and I think it's something we need to acknowledge and think about in the interpretation of the data because these didn't have a choice. Essentially, didn't have a choice because we're just pulling the data out of their records versus these ones that are limited by the ones that wanted to enroll and do it. The reason we didn't randomize everybody was we really wanted this arm to be completely not contaminated by it's a pharmacogenetic study, and I have a drug that may be relevant, but now I'm not going to get genotyped, so them going out and getting genotyped themselves. So there's some things like that. In the pragmatic trial, we wanted the control arm to be as clean from that as possible. We don't know how many that really would have been, and it also from a budget standpoint, if we would have contacted all of them for multiple reasons we didn't. It's a big number. We will do an analysis both as a total intent to treat, where these ones are put into here because some of the hardcore statisticians, say, well, you randomize them into there, so they've got to go in there. So we'll do the analysis actually both ways. but with that many, it's not likely to show anything in that case. So Eskenazi is one hospital, has and a variety of outpatient sites around Marion County. Again, it's phone recruitment, and it's in-person enrollment. IU Health, we were enrolling from 14 of 16 hospitals locations, 122. We look back at the clinics that they were enrolled from, and it was 122 different clinics that we actually enrolled somebody from. And this is all entirely phone recruitment and online enrollment. So this is our enrollment graph, and I'll show you the next slide, a few arrows on here. This is the genotyped arm, and this is the control arm of patients that were enrolled. So if you look at it, there's a couple points on here that there's something that's worth noting. Here is see how the control arm was rapidly increasing, but it wasn't a inflection point there. So we realized in that enrollment not being as successful as we thought in the genotyped arm, so we actually changed the randomization algorithm here to a self-correcting algorithm. So what happens is it goes 2 to 1, but it's actually keeping track of how many patients are in the genotyped arm and how many are in the control arm. And it actually increases the number that get randomized to the genotyped arm until that number stays at that 2 to 1. So it turns out it's about 80% of them, 80% of patients actually get randomized to the genotyped arm in order to get that 2 to 1 ratio. That was the explanation for this inflection here. Then here you see this very disturbing flat line here. What that is during this time we were enrolling from Eskenazi, and they had their home brewed medical record system in October it was October actually when they switched over to Epic, and because we need these reports generated every day, right? They were way more concerned about getting orders, getting the physicians, getting the billing done, all that stuff, and our research protocol was way down on the queue as far as prioritizations to actually get implemented in the conversion from conversion over to Epic. So basically, for 3 months in there, they didn't generate any reports, and we couldn't actually enroll anybody. So that's what that was, and then finally we got going again, and then you see a big inflection point here, and this is when we started the rollout in January of 2017 into IU Health, which is a much bigger healthcare system, and that's why you start seeing that dramatic shift. So, yep.
Could you say more about eligibility? Like, so I know you had a list of genes that were included, but what about the patients themselves? Like, are these people who are, like, I don't know, is there anything more you can say about the patients? Are they people who are, like, they're already starting to be prescribed, and then that triggers the alert? Is that, I'm sorry, you said that, I didn't catch it.
It's just, so the only inclusion criteria, with one exception, which I'll get to in a second, is that they're getting one of those 27 medications for the first time, right? And the one exception is for the proton pump inhibitors, because we limited that to things like serious indications like GERD or ulcers or that sort of thing. So that's the only one that had any other inclusion criteria. So very pragmatic, real world sort of a trial.
So they're already considering these medications.
So it's triggered by a prescription that the provider, usually a physician, but some cases nurse practitioners. So it's triggered by the alert or the list that comes to us is triggered. They're including that list because yesterday they got a prescription entered into the medical record system, either into Epic or Cerner. And so that's what activates the thing. So it's not just that they're considering it; they actually have a prescription entered in. But it could be, the different things. So, like codeine could be for pain, could be for cost, some of those sort of things. It turns out it's about half and half. Amitriptyline can be something for neuropathy. It could be for psychiatric effects. It could be for sleep. So it's not. We didn't limit it down to any specific indications for really hardly any. Sacramentos could be for whatever transplant.
Did you compensate these subjects?
So
Did that help with enrollment?
Interesting thing. So initially we worked, okay, and then as we were when we were in this phase here, it was like, okay, we're not getting as many people as we wanted, so we actually went back to we talked to some of the other people on our team. So, well, they're underserved populations. $25 is a big deal to them, right? And so we did $25 for a little bit. Didn't help a whole lot. We actually went up to $50. So we actually, from about here, somewhere in here on, they got $50 to cover, basically to cover to come back. And it was given as a gift card to Walmart, I think was the one we're in. So yeah, if they come back after they get their blood drawn, then they get that. The remote ones, IU Health, we actually just mail it to them because we don't actually see them in person. And we didn't really quantify how much difference it actually made, but I think it was totally the right thing to do and appropriate. Questions? So this is some data looking at the enrollment, and this is the percent enrollment success of the people that were randomized into the genotyped arm. What percent of them were actually successfully enrolled? Right? And so this is looking at the blue line is the Ashkenazi patients, right? So it was right around 5%, and the IU Health was up around 10 to 15%. So the actual successful enrollment rate was much higher. How much of and we actually have the data or the reasons for this because the people who were calling them, said either we couldn't reach them, and we tried calling them for up to 5 days, so they had to come back and get their blood drawn within 5 days of the trigger med prescription. And then we have documented why they weren't actually enrolled, where they never able to be reached, and they not want to, where they're not able to because they're too busy or whatever. So we're in the process now of putting that all together to figure out exactly what the difference is between those. This sort of puts it in a different way. This is the number of calls made, so the attempted calls made per success. So the graphs look pretty similar, right? But it takes about, for IU Health, it took about 10 to 20 calls to get an enrollment, all right? Because a lot of times they didn't answer the phone, they didn't, or they declined or whatever. Versus with the Ashkenazi, which is, even more of an underserved population, and we're looking at like 50 calls per successful enrollment. And so I think this, going forward in some of these other trials where we're really looking at these sort of populations, it takes a lot more calls than what we're used to in these sort of environments. So this is some of the demographics of it. Still, the majority are white, but it's about a third African Americans, Black African Americans. Some of them are unreported, so about 10% of them we couldn't actually figure out. And this is partly because of the control arm, we didn't actually go to them, so we had to pull that out of the record system. More than one, there's a few of those, a few Asian, relatively few of these, and a couple of these, and a total of about 4,500. So we can get most of that from the medical record system. And this is obviously a picture of Indiana. So within in Indiana we have what's called the data warehouse, or called the Indiana Network of Patient Care, where almost all the hospital systems dump all their data on a fairly regular basis into this INPC, which is a huge database that's got from a whole bunch of different medical record systems. And within that system, we have the ethnic and racial classification, or whatever they report as, the patient reported information in over 90% of them. And also, over 80% of them have actual geocoded addresses, so we can track back or take that information and back and track it into these medically underserved areas and populations to figure out what percent of the patients were in those areas, because we have these geocoded addresses. And then, so for instance, we could tell 42% of IU and Ashkenazi patients, this is healthcare system-wide, so the entire population. 42% of them, of IU health and Ashkenazi patients combined together, are in either a medically underserved area or population and have a healthcare facility around there from either IU health or Ashkenazi. Obviously, downtown is the Ashkenazi and the University Hospital and a couple other ones that are IU health. But what these are is the different colors are either the blue is medically underserved area, this one with the crosshatch, in this crosshatch star, it's called the governor's exception, which even though it's not a federally designated underserved area, the governor has the authority apparently to declare them for some reason or another as a underserved area, and then the green ones are medically underserved population. So it gives you an idea of around the state of Indiana where those populations and areas are, and you see the little red H's in there are the IU health healthcare, so the hospitals, actually the main hospitals for IU health around the state. So you can see they're pretty well populated in the different areas, and if we look then, so we can go back to our INGENIOUS patients and map them back and say, okay, which of these areas have we enrolled people from? And if you if you look just at the numbers, so 65% of Ashkenazi and 31% of IU health patients are from what are classified as medically underserved areas. And the red ones are counties where we've enrolled patients from that are medically underserved areas or populations. The gray areas are where we've enrolled patients, but they're not considered underserved areas or populations. So you can see downtown, there's, this is, a lot of this is Ashkenazi, but not all of it. There's some of the IU health ones too. And then you see the suburban areas right around downtown, that's not, and then you get out into the really rural areas where we've actually reached out into these hospitals that are out there and enrolled patients from out there. And so we can, we could now, that we've got all this stuff going, use the geocoded information within patients as we're, as reports are coming through. We can use those to specifically target the patients if we wanted to in the underserved areas of population. We didn't actually do it in INGENIOUS in this trial because we were developing this sort of stuff as we were going. And initially, it was planned on only being Ashkenazi, but as you can see, still, still a very high percentage of people were from those particular areas. And this, so this is the of the subjects that were genotyped, and breaking that down by whether they had an actionable genotype result or non-actionable, and there was about a third of them did have an actionable genotype. In the there was only a few. This is a question I came up earlier today. How many of them actually need a consult? So this is when we send the information to the provider, if they have further questions, there's a thing on here. It's like we have a clinical pharmacology consult, a pharmacogenetic consult. They can call back, and very few of them actually did, and very few of the total amount that were had the actionable result. So this is the distribution of the most common drugs that triggered enrollment into the genotyped arm. So this is only the genotyped arm. So there's about 1,300 subjects that were genotyped. As I mentioned before, about a third of them had actionable genotypes. They vary depending on the specific gene that's used to genotype for that drug, so that varies differently, and I'll show you that in a second in the next slide. And then all the genotypes were actually reviewed by adjudication committee, the gene-drug interactions, and then which is a group of pharmacogenetics people. There's a fellow on there that we rotated through each month, and then a physician who's part of the team, which is the one who would actually report the results back to the prescribing physician that prescribed the drug that they were enrolled in. And so these we did not actually, we took all covers. We didn't limit it to any of the different drugs. So the most common one that was enrolled in the trial was tramadol. 233 out of the 1,300 was tramadol. This is the number that had an actual genotype. So you looked at the main ones up on top are the two pain meds and the psychiatric meds, antidepressants. And then you get, there's also the PPIs, which was limited to just a few indications, and then some additional psychiatric meds, cardiovascular, and then a couple other ones that had only one or two, or less than 10 patients. So this is one of these ones, so these two drugs, are ones that, as I'm going around talking sometimes about pharmacogenetics, that I get a response that's like, well, why do you even deal with amitriptyline? Nobody uses amitriptyline in the US, it's only in the UK where they use tricycline, they do therapeutic drug monitoring and all this stuff. Well, yeah, that's not the case, right? I mean, there's some other indications, but there are a lot of people that are actually getting amitriptyline for other things, for peripheral neuropathy, for pain, sleep, some things. And the other one was codeine, and there's a two-phase response you get to this. Number one is it's a lousy drug, nobody ever uses it. Well, that's not the case, right? So there's a bunch that do. It's much limited, it's more limited in kids now after the FDA warning. But then it's like, well, that's all for cost. Actually, half of these, roughly 50% of these were for pain and half were for cost. So there is actually still, despite what a lot of people think, there is still a fair number of codeine uses available. And we will, as part of the IGNITE network, there's a big what's called a CPIC prescribing study where we're actually going, and it's most of these, there are a variety of these drugs where multiple sites are going and looking to actually see how many over the past several years up until present, how many patients within each of our healthcare systems are actually prescribed these drugs to actually, address some of these things where people say, well, some of these drugs aren't actually. You guys, I can't remember, you guys participated in that, in the secret prescribing study? Okay.
The VA is not participating in this study, but amitriptyline are heavily used in the VA environment. Not all anymore, but they're very, very widely used. And if you think about the VA population and a large percentage of U.S. healthcare, that is.
Yeah, no, that's a good point. Yeah, because there isn't any, unless the patients went to another hospital, so we're not, specifically, the VA, our Indianapolis VA is not part of this, trial.
Did you guys do any comparisons with this group to population frequencies for the alleles? See if your population is reflective of the literature regarding.
Not any formal. Okay. We haven't done a formal thing, but based on the fact that just looking at the frequencies, I mean, I would see oftentimes I would see the genetic. They all look pretty typical. Okay. So I don't think there's any real outliers because we targeted any population or anything. Because there's somebody who has depression or something like that as a link to that. So I don't think there was. We didn't. I think it's pretty typical. The ones. So like here, so the tramadol, we went with there's different sets of guidelines for this. So there's the U.S.-based CPIC guidelines, so those of you don't know, the Clinical Pharmacogenetic Implementation Consortium, which is a group of us that have created guidelines for using genotype for guiding therapy for a bunch of these drugs. So there's those guidelines, and they're very similar to what's called the Dutch Pharmacogenetics Working Group guidelines. And then there's also a Canadian network for pharmacogenetic drug safety or something. I can't remember exactly what that is. But they're all very similar. One of the differences is that tramadol is in the Dutch guidelines. They say if you're an intermediate metabolizer, so you have one non-functional allele, or actually one non-functional and one loss of function, that's contraindication for tramadol. So we went with that. That's why we have a little bit higher number than in the CPIC guidelines, because as long as you have one functional allele, you're probably okay. So that's why that one's a little bit higher than what the I don't know if you can you see that in the back, because the actual numbers. Basically what this is it's sorted by the same, that data, same numbers, just that it's sorted by the percent of actionable genotypes. And so up here you see an amitriptyline has both 2C19 and 2D6, right? So all you need is a genotype in one or the other. So that's probably why that one's higher. And then some of these are really low, so okay, we had 4 people on tacrolimus, but just by chance we had 2 of them, so that's 50%. All right, but you know, and here 1 out of 2 in efavirenz, so some of these are high, but it's just sort of sorted in the other direction. And you really need to, you know, have enough people to really make it make sense. Yeah, so we because the here is tramadol was the number 1 most common one, right? So we had a fellow who went and actually went and looked in all those. It was actually done a while before we completed enrollment. So that was about 120, I think, people who got patients who were enrolled based on their tramadol trigger medication. And so the question was, this is one of the primary endpoints, so we could start doing this, but was there could we see any difference in anything that happened in these patients between the patients that had the actionable genotype versus those that had a non-actionable genotype? The idea being, you know, did the provider really follow our recommendations and actually do something about it? And so this is a part of these pragmatic trials you get into when it's like we're not limited by anything, right? And so this was a pain medication, and we were interested in things like, did they change the dose? Did they change their medication from tramadol to either methylphenone or to one that's not metabolized by 2D6, or some sort of medication change that would indicate either, primarily what we were interested in, that the provider was following our recommendations. Right? If nobody changed any medications for them, then it wouldn't likely be the case. So we started doing that, and with these pragmatic trials, you start going through and you see a variety of things which make some of the interpretations difficult. Like in Ashkenazi, if you get a positive drug screen, urine drug screen, you're automatically no more opioids for your period. No questions asked. You got positive screen, you're done. Right? So there's other cases where we had a couple that were diagnosed with breast cancer, or they got hit by a bus, or had some other major trauma thing. So that's going to sort of confound these things. But if you're doing a pragmatic trial, that's the sort of data you get versus a very focused, limited one. So Kathy went through and said, okay, if we eliminate all these spurious or these other things that might impact us, we could try and see if the providers were really following our recommendations. It got down to a pretty clean set that didn't have any of these other things. So she went through and did a complete chart review on every one of them and looked to see how many either discontinued tramadol, had a dose change, or had an alternate opioid prescribed that wasn't attributable to some other, getting hit by a bus or something like that. In the patients that that did not have an actionable genotype, there was still 60% of them had some sort of a change of some sort, but in the ones that had an actionable genotype, 92%. So they're pretty small numbers here, right? But it does look like one of two things happened. Either one, the providers followed the recommendations, right? Or the people with the actionable genotype just weren't responding or having adverse events or something, so they actually switched it. And, it could be that the providers totally ignored us, but it just didn't work in them as we expected. We don't really have a real good way to figure that out because it's not always documented in the notes, even though we looked at these patients, switched them because X, Y, or Z. Yeah.
What was the average turnaround time from the time that the prescription and the time they actually get the report back?
The message back. So by the design of the trial, they had to have the genotyping done. We had to have the sample done. We had to have the blood sample in the lab within 5 days of when the insulin trigger medication was prescribed. Right. So it had to be in the lab then, and then it was a matter of a few days before they would get it turned around. We haven't calculated the average actual turnaround time. It's going to vary from a couple days after it to by the time the genotyping was done, you know, it could be several days on top of the 5, so it could be up to, you know, 8 or 10 days potentially, which becomes a concern for, you know, if they were in the emergency room and they just got tramadol and they were only going to need it for a week. I think, is that what you were?
Well, yeah, the idea that, lack of response.
Yeah, so they could, during that time period, they could definitely have been switched. And we can actually go back and figure out if they're switched before the provider actually got the report, because we know when that was done, because that's all documented exactly when they got the report. And related to that, so when we, you know, we're trying to figure out which of those it wasn't, so we actually, I asked all that we have 5 or 6 physicians who are the ones who are sending the information back to the providers. So I asked them all, like, did you ever get anybody that actually responded back, and the providers responded back and said, this is all bullshit, I don't believe this, I'm not following the recommendations, all right? And none of them could think of any times over the entire period where anybody did that. So I think they're probably, so there wasn't like this, you know, that big, backlash like that. But that doesn't, if they didn't say, you know, no news is not necessarily, you know, conclusive here. So,
I guess one question I think I know, but did you say that this was just going to providers, like you didn't provide any information to patients at all? And I wonder if that, like, what impact that might have.
So it was interesting based on what Defense was telling us last night. No, so it's going into the medical record, so it's actually in there. They know they've been genotyped, so there's that. What we did, and I'll towards the end, I'll give you a few notes about some actual focus groups with the patients after they've completed the trial. And basically, the bottom line is they want the information, they want it, but I'll get to that. But there's not at this point there. We didn't relay any of the information back to the patients. It all went straight to the provider. Whether the provider gave it to them and told them, we don't actually know that.
So in hindsight, do you think it would have been useful and, I guess, valuable to then follow up with the providers, like with a short survey or something like that, and ask them?
Sure. I think you know, had we had the resources, you know, I think absolutely I would like to know that. I think it would be good to let the patients know, or you know, educate them about what it is and what the interaction was, what the drug was, why it's happening. You know, all that communication I think would be very valuable. Yeah, so I think definitely. And we tried doing, you know, we did some education activities for providers, but you know, we're across the entire state right now. And we did some CME type things and stuff. But quite frankly, the number of people that came was not huge, even though we tried giving them lunch. It didn't get a lot of them to come. And some of the ones that came were ones that sort of knew it anyway. But there was some, you know, and there was some attempts at that. And but we did have the consult option, so it said, if you have any questions, here's the number you can call. And that was a physician, pharmacogenetics trained physician on the phone. This is just a little more detailed information on that. So the participants who had actual genotypes were likely to have tramadol or codeine discontinued, so they stopped it, and alternate opioid prescribed within 90 days. So this is one of the other things that we're looking at. We're probably going to do multiple different secondary analyses. So within, you know, a 3-week period or a 90-day period or something to try and eliminate some of those other things that happened during the whole 1-year period to see if there's differences. So we did do some of that. You know, and there's some side effect things that were, you know, indications that when they switched, it might have been better. But some of the, you know, not all of them. So it's just some of the things that we're looking at. And so what we're now actually doing, so actually I think it's on the next got 4,500 patients, right? Going through every patient's charts and having, you know, somebody who knows enough about the way stuff is entered in and everything is not really feasible with what we've got to actually do that in a detailed manner, like we did in the tramadol patient. So, and what we originally proposed was pulling this stuff out of the medical record system. So what we're doing now, as we're waiting for all the data to actually be collected or put into the EHR, is we've got people from registries that do a lot of this data mining, and so we're having them come up with their best way. We are all together come up with the best ways to try and pull out the adverse events, and then doing it on a select few people, and then go back and manually review those charts to see, you know, what did we miss, or what did we pick up that were false positives, so we can go back and, you know, use it what's in the literature and what they've done in the past, and what we think is really happening, and basically going through this, you know, sort of not really an algorithm, but a method to try and figure out what the best way is that we can actually pull out some of these. And the other complicated thing is, you know, the adverse events for tachycardia different coding for some of these. So you'll have to do it separately for each one of the drugs. I think it will be valuable for a variety of people, more than just us, to actually figure out some of these. So the economics part, right, which is one of the primary endpoints. I've learned a lot about healthcare economics, and I think based on our discussions in the INGENIOUS group, I think a lot of people have, because there was a lot of things like terminology and stuff like that I didn't, you know, seemed as a pharmacologist or genetics person, seems like, you know, a cost assessment, there's this cost data, it's all, you know, no, those two things, for example, have a dramatically different meaning. So when you start engaging the economists into it, you have to be very careful about what you're actually, you know, saying. I mean, in the same way, it's like they're looking at our things, saying, it's a SNP, a SNP, whatever, it's the same thing, right? Well, no, it's not. You know, it's different. And it was interesting because you would see occasionally we would start getting these discussions, and it's like, you know, we're having these, you know, arguments going back and forth, and then we would realize, like, oh, because you're talking about one thing and you're talking about another. We think it's all the same. So, and it happened even in some of the IGNITE meetings when we were talking about it. So and these were people that were involved in the beginning. So these are informatics from Reagan Street for Center for Computational Biology and Bioinformatics, our economists in the School of Public Health, and then us, goofy geneticists over here. So we started pulling out some of the data. So this is another thing, and we're now starting to pull this out to see what it looks like. So we're starting with Ashkenazi. So just to test it to see what they look like, we randomly picked 20 subjects that have completed a 1-year follow-up, and collected actually 12 months before and 12 months after that their prescription or they were enrolled, and identified a bunch of costs. The GENES report and look at it so we can see what they look like, so we can figure out the best way to do it. Well, on these 20 patients, 7,700 rows of data, of charge data, just for those 20 patients, right? So, you know, it all kinds of different things. It's charge data, not cost data, and it's not reimbursement, it's not cost, it's charge data. It's charge data for while they were in the hospital, you know, so there's a variety of these things that now we're actually sorting through, but if this is representative of the entire 4,500 patients, there's going to be a lot of actual data to go. But I think also that, you know, there will be a lot of things we can learn from that. And what it doesn't, you know, there are things that it doesn't cover, right? So there's some limitations to this, and again, from a pragmatic standpoint, it doesn't include, you know, the costs for training, for data collection. If somebody is actually, you know, in the real world, somebody's writing this down there into the chart, any information processing, you know, what's going on, which, you know, would have to be part of it. And then there's, you know, these problems that, you know, people are well aware of. I'm sure that ICD-9, CDC codes, and basic codes are, you know, often used based on how they'll get the best reimbursement. So there's some problems with that, but also this is stuff from the healthcare system. It doesn't include things like if they go into a rehab, afterwards, the number of sick days, and some of these things. If you have an adverse drug reaction or your clopidogrel's not effective and you have a stroke and you end up in a rehab thing for a year or two or the rest of your life, those sort of costs are not calculated here too. So it's a limitation for these sort of things, but things that are worth discussing and thinking about how to address. And also we don't really have the power to do gene by gene interactions, comorbidities, although we'll try and correct for some of that in the polypharmacy type stuff. So I'm in looking at this, trying to learn what other people had done, for these sort of cost-effective analyses. So I went back and looked, and there's an article from, this was 2014, so 2 years ago, but there were, they looked at basically the published cost-utility analyses of personalized medicine tests. So these are basically, they're mostly genetic tests, is what they, in fact, I think they were all genetic tests. So there was, at that time, there was 59 of these publications in the literature looking at that. Compared to, like new pharmaceutical or any drug costs, there was 1,300 of them. And of these ones, 39% of them were somatic mutations versus germline. So the number of actual tests like this that have been done is pretty small, especially when you look at, this is from, sorry, I forgot to put the reference, where there are supposedly now over 75,000 genetic tests in the market now, and if you look at the time period from 2014 to 2017, this is the cumulative number of new genetic tests on the market. So just in this 4-year period, there was another 14,000 genetic tests. And this doesn't mean different variants, but it's just different tests that, quite frankly, the third-party payers, insurance companies, or Medicaid trying to figure out what should be reimbursed and what shouldn't. So you figure that, and there's been a grand total of, or at that point, up until here, 59 studies to try and address that. So there's a huge difference in the data that needs to be done, because that's, the reimbursement is going to drive a lot of these options. And these are, just some things we need, need to look at all the costs of precision medicine, things that we need, the variables such as comorbidity, socioeconomic factors, figure out what other major determinants, how do we get the data out of the EHRs, because we're not likely to be able to do this all manually, and decision analysis to try and figure out the risks for the different things. This is based on feedback that we got, I think, from a couple of meetings at INGENIOUS where we had payers there. Quite frankly, they're interested in what's going to happen in the next year, because 30% of the patients switch their insurers every year. We also need to keep in mind, I think, that really the insurance companies and the payers are really custodians of our money that we actually give them as insurance premiums, right? If they, and they say, if you're, there's places in Silicon Valley where the companies say, we want to do all kinds of genotyping stuff, so they'll do whole genome sequencing and whatever, but your premiums are going to be way higher because that's what's there. They're just sort of the mediators of that, so it's really up to us how much we want to pay and how much we want coverage. So, just to make it, you make the point that it's not really us against them, we are them in a way. We're telling them what they want. A variety of other sort of things. Genomic results can relate to a variety of other things, counseling type things, and some of it has limited clinical utility. And so this was the one, and then I'll stop after this thing, and I go for more questions. So Peter Schwartz is our director of our Center for Bioethics, and he's interested in this, should we and how do we get the information back to the patients? Right, so he did some small focus groups. Each one had 10 to 15 subjects in it, and these were INGENIOUS patients that have already completed the 1-year follow-up period. And and they agreed on our consent that they could be contacted again if we had more research studies. And so we called them up and asked them if they wanted the genotype reports back to them, because we were not giving it to them at this point, and should the providers have access to it, and so a variety of discussions like this. The bottom line is they want it. They want it all. They want the providers to have it. They want the providers, all their providers, to have access to all of it. They're not concerned about security of it. In medical records, they assume that that's safe. It's way different than Facebook and these other, things. Because that was all going on, in the last recently. They're way more concerned about that than they are about their genetic data being in any sort of medical records system. So, it's like they want the actionable stuff. They want to know what to do about it. They want the non-actionable stuff. It's just like, give it all to me. I want it all, even if they don't know what to actually do with it. And they want to know where there are resources that they can go figure out what to actually do about it.
And they want the providers to know what to do about it. Right?
Yeah.
Or that's the expectation.
Yeah. They, yeah.
You said there were multiple focus groups. Were they different from different areas of the state? I mean, so
No.
rural versus downtown, or no?
They weren't separated out by that. It was not in the initial ones, because this was sort of initial ones just to figure out what sort of things would be useful that they might, to get the initial feedback to actually then devise other additional focus groups to figure out more stuff. So this was just sort of a random selection. It was in Indianapolis. They had to come down to do it, so I don't have the exact geographical locations, but it's not likely that they were the ones in the northern or southern part of Indiana. I think they were mostly ones that were around downtown, but they weren't limited to anything. But I think that's one of the things now is seeing this that's actually worth actually exploring. So is there differences, or should everybody actually? And one of Peter's interests in this was several years ago was because there was an impression that some people might not want their providers to know their genetic information. So he was actually looking into some of these things. Should there be parts of from an ethical standpoint, parts of the medical record system that should be blocked off that, so the providers, could know, because maybe they, similar to, maybe they wouldn't want their providers to know that, they had a sexually transmitted disease, that they had, some sort of psychiatric disorder, some of those sort of things where the patients may not really want every provider to know in some cases for some reason or another. So Peter was kind of interested. I wonder if some of the genetic data might fit into that, and the bottom line is no. It's like, they're not caring about that. They want everybody to know. They want everybody to know what to do with it. It's sort of the input.
So you said that the testing is offered through your clinical laboratories. How often is it used? How often was it used outside the context of the trial? If they work with the same drugs, is it being ordered just regularly?
Random. And we are using it for some of our strategically our genomic, our oncology patients that are in the we call it precision genomics oncology clinic, which is for patients with refractory disease or tumors of unknown origin that get whole genome sequencing done on the tumors. So for a while I was running the same chip on that, and then I'd sit on the tumor board and say, okay, so there's that was mostly DPYD, and then we're starting to do it in the pediatric equivalent, and so TPMT is a relevant one for that. But most so there was some of those that was purely for clinical purposes that was being supported internally, and that's cool money. For the adult ones, is basically dried up. There's some people in the cardiovascular people that are using it, but to our knowledge, at least through our genotyping lab, very few. There's some that can be sent out. Another story about working with the pathology department and getting things going, keeping it internally versus being sent to other places. And I think there's a lot of financial implications probably of that. But there may be ones that are going out, and maybe people that are getting it done totally, clinics that could send it out and have other people, do it. They come in through our lab. I think it's more than based on the number of pharmacogenetics genotyping that's done nationwide, which is huge, a lot, or at least it was for a while, especially when the companies were making like $1 billion on it, before it sort of got reined into, more reasonable things. There was a lot of it being done, across the country, as the thousands, a week, were being done for a while. So I'm sure there are a lot of people that have it, but not coming through our lab, and I don't have any good way to tell because there's not a good place in at least our Cerner and Epic thing to put that sort of data.
But is your suspicion that it was going out just not through your laboratory, not other people? Just not being done?
I think it's not being done almost hardly at all. We have talked to, some of the orthopedic surgeons, some of the psychiatrists, the transplant, people, and none of them are, even downtown, in the university. Occasionally, maybe on, like a really, extreme responder. And I think it's driven primarily because it's not reimbursed for the most part. And they don't.
That's one last question. The prescription that's ordered primarily being used for that index prescription that's put in there at the moment. Sense of how much the report is being reused over time. I know it's sits in the EHR and PDF, but sense of how many times.
So we, for that year follow-up, we actually monitor, and we're still getting that daily list, right? So we see how many times they get another script. It's out of all these people, even now, it's a handful of months.
Are
Getting a new start on a second one of the 27 medications. So that's probably maybe 10, and not much more than that, I would think, that are getting a yeah. During that 1 year.
and then you ping the provider and say, hey, here's the results, make sure you incorporate.
If it's actionable. If it's not actionable, then we don't actually do it. So it's Well, I thought it'd be maybe a little higher than that, but it's only during the 1 year period. So I think there may be, and we don't, it's not all of them. So. Right. If anybody wants, so I had a couple other slides in, but this was a good discussion, better anyway. If anybody's interested in the high throughput functional assays that we're developing, I'm happy to chat after that, or sort of additional.
Thanks, Todd, for
All right.
being here.
What I didn't put was the acknowledgement. As you see, there's a ton of people that had to make this happen, both from the lab and
How are you guys going to handle the